All right, everybody, welcome to Pneumatic Pump Bootcamp. I'm Tony Gasparis. Everything you need to know on pneumatic pumps. And this is a educational program put together by Tactile Medical. And with me tonight, I have three great speakers, Steve Elias, Steve Dean, and Manu Agrawal. And we're going to try to explain some of the things, the nuances of pneumatic pumps that most physicians that are treating patients with lymphedema don't really know the details of. And really start off with Steve talking about the difference between a 651 and a 652, or a simple and advanced pump. Then Steve Dean is going to go through some clinical cases on decision making on which patient needs what type of pump. And Manu is going to finish off with management and beyond with, again, some clinical cases. So for everybody that's on the call, please, any questions, we want to make this very interactive. Put them in the QA box at the bottom of your screen, and we'll interrupt the speaker so we can ask as we go along and make this as interactive as possible. So Steve Elias, go ahead and let's get started with 651 versus 652.
Okay, thank you, Tony. And again, we're saying that this is pneumatic pump boot camp. So we really want to take you through the basics of management and decision making, as Tony said, and not get into the necessary minutia of lymphedema per se. Once you've made the diagnosis or have a swollen leg, what options are there? And here you can see in this picture, all of us who treat venous disease and obviously who treat patients with lymphedema or lipedema see patients like this all the time. And Tactile Medical does offer various products to help us manage, and that's exactly what we're going to go through. So next slide, please. These are the two pneumatic compression devices that are available. The EO651, which is really the more basic pump, the entree system, and then there's the EO652, which is the FlexiTouch Plus system. And before I go any further, Jenna, could you pull up the 1, 2, 3 slide? We want to ask the audience some questions. So choice one is I've used only one of these. I've ordered only one of these pumps for my patients. Choice two is I've ordered both types of pumps for my patients. And choice three is I really haven't ordered either one. So choice one is you've ordered one or the other. Choice two, you've ordered both for your patients. And choice three is you've never ordered. And don't worry, it's anonymous. We're not going to know who said what. So if all of you who are listening, could you please just vote, help us out to get a better understanding about what you all have done.
Is there a correct answer, Steve?
There is no correct answer. This is a poll, a poll like who's winning in the Republican, race or something like that. This is not a right answer. So, okay, so the great majority, about 2/3, Tony, have ordered one or the other. About 20% have not ordered either one of these, and about 18% have tried one or the other, and 2/3 have ordered both, as we see here. Okay, so good. So now we'll get a little better idea. Okay, so what's some of the differences here? Let's go to the 651, and really the more basic. No, back slide, please. Good. So the basic pneumatic compression, the entree system you can see here is really good for chronic swelling, venous ulcers associated with lymphedema, and a chronic venous insufficiency. And then you can see they both go up the entire extremity. The entree is really more of a zipper type of device, and the FlexiTouch is with a Velcro type of device, which we'll get into a little bit more specifics. FlexiTouch is definitely more advanced. It gives patients sometimes a little more comfortable way of managing it, and we'll talk about why it perhaps is a little more comfortable way. And it does help with lymphedema as well as chronic venous insufficiency and leg ulcers as well. So these are the two types of pumps, and we're going to talk about the differences in them and when you might use one versus the other. So now we can go to the next slide. And if anybody, on the faculty here, you want to jump in, please just jump in. So the entree, the plus, the basic one, is really, there's 4 different sizes. It uses the zipper configurations. There are 8 chambers in this basic pump, and it really begins distally, meaning at the toe level, and moves lymph fluid proximally. Treatment is in general a 60-minute treatment. There are different pressure options, and clearly you can use it unilateral or bilateral. And you can see on the leg model here how it begins inflation at the foot level, stays inflated, and moves up, stays inflated, stays inflated, stays inflated. All chambers inflate. Now they're inflated, and then they all deflate. So it's not a sequential inflation and deflation. It's a sequential inflation of everything, a hold, and then it deflates. And keep that in mind when we talk about the difference.
Hold and squeeze. Hold and squeeze.
Hold and then squeeze, right.
And what's the duration of that whole cycle from start to finish? Steve, do you know?
The whole cycle? I think we have that on the next slide or something.
30 seconds. Yeah.
30 seconds, right? I think,
Right.
yeah.
So the patients are being, like you said, the hold and the squeeze. So it's a leg is being squeezed for, around 30 seconds, as opposed to the more advanced pump, which, as we said, one of the things is perhaps it's a little more comfortable for patients because it's not a hold and squeeze type of action. And you can see the indications here on the right side for the Entre Plus or the basic pump. All right, let's go to the next. So here now you have the Flexi Touch, which really is designed to really mimic, not just mimic, but act like an automated self-manual lymphatic drainage device. And it's a little more gentle in the mechanism of action, which is more dynamic. The chambers are narrow, and I'm going to show you on the next slide a video of kind of how it works. And the chambers inflate for 1 to 3 seconds. They deflate, and then the chamber above that inflates and deflates as well. So it's not a, inflate and hold type of thing, as Steve said. And it does provide drainage from truncal, if necessary, clearance first, meaning getting rid of the reservoir above, meaning emptying that reservoir, and then begins distal. So Steve is going to talk about when you might use this device versus the basic device, especially in patients who have significant truncal edema aside from lower extremity edema. It's a little more programmable and compared to the Entre device, and also the Velcro closures allows for some extensions. If you have fairly large legs, you can really fit it to each patient's body type. And
Yes.
Go ahead, Steve.
Yes, I was just going to point out, what's unique about the 652 devices is you can selectively manipulate the pressure in the chambers within one region.
Right. So again, it's more customizable for the patient.
Selective manipulation.
Right.
So if you have an area that's more fibrotic,
you want
you can increase the pressure there, right?
Right. And we'll get into how you decide and what type of help the reps from Tactile can give you in deciding exactly how you want to program the Flexi Touch as well. And it obviously takes a lower extremity, half a leg, a full leg, and trunk, thigh, upper extremity, and also for head and neck. The indications here you can see are a little bit longer than the Entre Plus, and you can read them, as well as I can. But some of the things we want to highlight in those of us who treat venous disease and lymphedema is obviously this lymphedema. Upper extremity, we'll see some of that, but mostly we're seeing patients with venous insufficiency, wounds, as well as lipedema. And then, of course, there's phlebo lymphedema, which is really the largest cause of lymphedema in the U.S. For patients. So this is a more customizable device. It's in general perhaps a little nicer for patients. We'll show you. Go to the next slide. Here you can see how it's working. Each chamber is inflating and then deflating for 1 to 3 seconds. And it is inflate, deflate, inflate, deflate. So it's a gentler, it's really mimicking manual lymphatic drainage more. Patients find it a little more comfortable because they're not having something, squeezing on their leg for a longer period of time, and then it allows for mobilization of the lymph fluid.
Yeah, Steve, as opposed to the squeeze and hold, this is referred to as a work and release technique. Yeah.
Right. So it's helping to move things, and it's more comfortable for the patient as well, for many patients. All right. You can go to the next slide.
I think the fabric's a little bit different. It's on the two. So the entree is just a little bit, perhaps maybe a little bit stiffer. And then the Flexi's got a little bit of a softer fabric. But the important thing for both of them is they have a zipper mechanism. So even though patients may Velcro themselves, they can kind of keep that Velcro, and then they can just unzip it and zip it back off for easeability of taking it on and off.
Great points.
Right.
And really, here is just showing you again how with the hold and squeeze and push, it basically kind of pushes the fluid up, versus with Flexi Touch, you're pulling on these anchors, anchoring filaments on the lymphatics, opening up the lymphatics to be able to reabsorb, to pick up the interstitial fluid and push the fluid along the lymphatic channels.
Right. Steve, you want to talk a little bit about when, because this is going to help them answer some of your questions, when you might want to add the truncal component to this and not just a lower extremity component, obviously when they have truncal edema.
My slides will cover all that, Steve.
Okay, so you're going to see, he never wants me to give you guys the answer.
No, he
wants,
doesn't like that, no.
okay, I know, we tried to get him. This is, we did this at the UIP meeting, and yes, we got pushback at that time too. All right, Stephen, I tried it again. All right, let's go to the next slide.
It looks like he's going to win the bet we had earlier too.
I know, for the number of participants.
Yeah.
You're batting 1,000 so far. All right, so here you can see all the various treatment options here as to when you're going to be using the Flexi Touch, and the point is, there's a lot of different treatment options compared to the Entree Plus, and it depends upon what you want to accomplish, where your lymphedema is located, trunk only, in the legs as well as a trunk, chest. Obviously, patients who have unilateral arm swelling secondary to mastectomy or breast procedures. So there's a lot more than just the leg that was shown on the diagram. And I think
there's a quick question on, and this we'll cover a little bit later on, but get the question out there. One of the participants asking, why is it that insurance requires a trial of a basic pump prior to ordering an advanced pump? Is there really any data or reasoning behind that, even if in patients who have established truncal edema?
Yeah, so for all of you, we're going to get into that later on, and we're going to show you the requirements from insurance and documentation, and then we'll tell you how Tactile can also help you in your documentation so that you have what you need. But now Steve is not going to let me say anything, but as to why. No, in general, the question is correct that if why insurance decides upon that, well, their goal is to start simpler. It may cost a little more of them to do the Flexi Touch instead, and a fair number of patients really will then be able to benefit from the Entree or the 651. So
yeah, that's their argument, that there's not enough data for the 652s.
Correct. We all feel, certainly someone has truncal edema, I mean, the 652s are really the way to go. But just like when treating, venous disease, is there any data that you need to wear 3 months of compression stockings before? No, but the point is, right, yeah. We don't know, we don't have great data to convince them otherwise. And unfortunately, they have the money, they make some of the rules. But hopefully as data accumulates, that will change. And certainly patients who have obvious truncal edema, it's silly to subject them to the Entree Plus to the 651 when a 652 is really what they need. All right, let's go to the next slide. I think here we are. So this is kind of a summary slide as to everything that we spoke about. And you can see here the differences, the characteristics of each one. in terms of the 651 and 652, and it's really being compared all the way on the right to manual lymphatic drainage. And you can see that there's similarities in a lot of them, but the difference is really in terms of the 652 and 651 we already spoke about. There's no truncal treatment in the 651, but FlexiTouch and manual lymphatic drainage can deal with that. Sometimes it's a little longer treatment time with the 651 compared to the 652, but 45 minutes to 60 minutes is not that big of a difference. We spoke about the chambers, how there's many more chambers in the FlexiTouch, and you can vary the pressure in the chambers depending upon where the disease may be in the patients. And we also said the 651 always just begins distal to proximal. In the 652, if you want to decongest your truncal area first, there's a proximal to distal for the first half of treatment to decongest or get rid of whatever's in the reservoir in the truncal area. So when you then go distal to proximal and are bringing that lymphatic fluid up, that the truncal component can accept it. It's not congested or ready. And manual lymphatic drainage really is proximal to distal. And the sequence of inflation, we spoke about that, how the 8 chambers in the entree all hold their chamber pressures until everything is inflated, and then it is all released simultaneously, as compared to the nicer 32 chambers that inflate one at a time for the 652 and deflate as the next distal sequential inflate. So it's a little more comfortable for the patients at times, and tends to move things along maybe a little more the way manual lymphatic drainage does as well. And finally,
I just want to point out to everybody, what really makes it a 652 or advanced pump set different, or at least from a reimbursement perspective, is the fact that you have this programmable feature, which you don't have with a simple pump. So all the pumps that are out there that are advanced pumps or 652 have that specific feature in order to be categorized like that. The difference that the 652 of Flexi has to other pumps in the market is the fact that the way the treatment protocol is. So you start proximal, empty the proximal reservoir, and then treatment goes down the leg. And then the second half of treatment is from distal to proximal, which is basically what mimicking the way MLD is done. So that's really what separates Flexi from other advanced pumps.
all right. So Tony, you want to go to some data?
Yeah, so we're going to just go through a couple of slides here on there we go. Okay. So there's not a ton of data out there, but I figured show especially randomized studies, but I pulled a few of them that are, I think, a little bit relevant. This is comparing, and most of the data, randomized trials are done with breast cancer patients, small studies. And this basically compares what happens to edema reduction when you add pump therapy to MLD. So MLD versus MLD plus simple pump. And you can see the reduction in edema is significantly higher by adding a pump compared to just MLD alone. There's another paper, again, similar patient population, small number of patients, again, comparing MLD to MLD plus pump, simple pump again, and you can see a much greater reduction in volume at 2 weeks, 30 days, and 60 days compared to MLD alone. This is the only study randomizing, comparing 651 to 652, same patient population. And you can see the advanced pump has a much better job in reducing volume, edema volume, compared to a simple pump, as well as tissue water content as measured with TDC, tissue dielectric constant. Finally, this is a claims data. This This is not a randomized study, but it's looking at claims payment from payers and comparing conservative therapy to simple pump and to FlexiTouch. The first columns here compares conservative therapy to Flexi, and you can see there's a significant reduction, 70% reduction in cost when FlexiTouch was used. Then this column compares conservative with a simple pump compared to adding FlexiTouch, and you can see there's still a huge reduction when you add a FlexiTouch pump compared to those patients who were treated with a simple pump. And the last column compares all the other advanced pneumatic compression devices to FlexiTouch, and again, a 50%, more than 50% reduction in cost. Now, importantly, in this paper, the major savings was due to reduction in hospitalization costs and cellulitis. Now, as far as coverage requirements, for a 651, there's 3 basic things that patient has to have. One, obviously, diagnosis of primary or secondary lymphedema. They need to have at least one of the following clinical features, either hyperkeratosis, papillomatosis, deformity of lymphatiasis, or skin breakdown with lymphuria. And finally, they need to have some type of conservative therapy for 4 weeks prior to prescribing a pump. Now, who would be a candidate for advanced pump? Obviously, they need to qualify similar from a clinical perspective, similar to 651, and they've had to had a 4-week trial with a simple pump, as was mentioned earlier. And finally, they need to have some documented truncal edema. So you have a triple whammy here that you need to have in order to be able to get an advanced pump. This here is a cheat sheet that Tactile has put together to help with Medicare coverage criteria. And the previous criteria, again, was for Medicare-based patients. But this can actually be a pretty simple way of following the requirements in order to be able to get a patient prescribed or qualified for a pump. Oops, sorry. Finally, there needs to be documentation of appropriate measurements of the lower extremities, and you can see here thigh, calf, and hips for each lower extremity, and it depends, of course, if you're getting bilateral or single limb, and that's pretty much it. Any comments or questions? Anybody?
As far as comments, when those measurements go, a lot of times if you don't take them in your office, if you refer them into a certified lymphedema therapist, they do all those measurements for you.
Yeah, and I think that's a good point. And I think the other point to make for that trial of the 651, our Tactile rep actually comes in and into our office and does the trial on our patients in one of our exam rooms. So if there is a requirement for a trial, that's kind of how we take care of it in our practice. I just have them come in. The rep just comes to the office and does it right there for the patient. So
does it right there in terms of utilizing the 651 for the patient?
Yep. So they bring the 651 with them, and then they trial it with the patient, make sure it's comfortable, do a pre-measurement of the limb and then a post-measurement of the limb to see if the patient got any reduction or if the patient needs to be in a flexi. If the 651 didn't really do much, then that patient may meet the criteria for doing a 652.
So if they need a 4-week trial, how often do they come to the office for that?
Yeah, that's what I was going to ask.
So they're coming in weekly in our practice to see the patients. So it just depends. So they've met the conservative therapy with compression. So concomitantly, they're seeing a lymphedema therapist, whether it's in our office or somewhere else. And if they need to do a trial of the pump, they'll do it within the office.
No, but we're asking, is the pump, when we do it, the patient takes it at home and
if they're having it at home, yeah.
No, and use it for the 4 weeks, and then if they develop truncal edema or whatever, or they don't get reduction, then yes, and they fit the criteria that Tony said to go to the 652. But are you
Yeah, and then they're
in your office, they only use the pump once a week for 4 weeks?
no, I'm sorry. So they'll come to the office because they won't necessarily go to their home to
All right.
see a patient. They'll usually let them do the trial in the office. It's just
I
one
see.
more visit for them to come, rather than going into their home, which, that all kind of got jumbled up with COVID. And so it kind of just made it nicer for the patient to come back into the office rather than the rep going back out to the house.
So one of the questions, with documentation perspective, is, how do you manage, or Steve mentioned earlier about the lymphedema therapist doing the measurements, but Steve or Manu, who does the measurements in your office? Let's say you see a patient, they have lymphedema, you want to prescribe a pump. Who's doing those measurements? At what point in time during their visit?
I have a vascular nurse that goes in before each visit and takes the measurements.
Okay.
Got a smart phrase. It just imports it right into the note.
Yeah, our MA does that.
We do that at every single visit, no matter what. It's just part of our protocol. Take pictures, get measurements, vitals. It's one of the vital signs.
Yeah.
Nice. Very nice.
Well, as Steve, one last thing, and as Tony mentioned when we were at the doing this at UIP, many of us have, you may think, oh, this is very onerous and stuff. First of all, you have a nice sheet that Tactile can give you the so you can check off and then know what you need to document. But more importantly, we do this all the time. Those of us who take care of venous disease, it's like second nature as to what you need to document. So it's the same thing. Once you start to get into it, you're going to put that in your notes. You're going to put everything that's needed, and it's a little bit of a learning curve. But again, your Tactile rep can definitely help you with these things, so that you have everything documented first time around, rather than going to insurance and they say you didn't do this, you didn't say this, you didn't say that. So it's not really as foreign as you think. Just think of it, you're learning another set of documentation compared to what you already know for venous disease.
I think that's a great point, because, oftentimes what happens is you're already seeing those signs and symptoms. Steve did a great lecture at one of the ABLS meetings several years ago on the dermatology that you see in your practice. What is papillomatosis? What is hyperkeratosis? What is lymphorrhea? You're probably already seeing it, but you're just not perhaps using the terminology. So just become familiar with that. I don't know, your slides are probably available somewhere, Steve.
Sure. Yeah. We'll have a future.
Well, your next ones are going to show all of them. So
future webinar on dermatologic manifestations.
Yeah. So Steve, nice intro to your slide.
Yeah. Let me share screen here.
But I think as you're pulling them up, I think this is one for those at least that don't have experience with Tactile. One of the great features they have as a company is the customer service, and both to the physicians and the patients that they provide, in order to make sure, therapy does get, there is access to therapy by patients, because we know that there is limited access to therapy when it comes to lymphedema, MLD and conservative therapy.
Okay. Ready, Tony?
Yep.
Okay. All right. So this is going to be an exercise in determining what's your best pump to order. Disclosure. Okay. So here's 2 representative limbs in your office. They can do better with a 651 or 652. And I like to poll this as far as polling the audience. What would you select? Wow. I never would have thought that. Okay. Well, there really is no right or wrong answer, but first of all, from my standpoint, we have obvious phlebolymphodema, uncomplicated phlebolymphodema, as Steve just referenced, the most common cause of lower extremity lymphedema in the United States. Now, from my standpoint, 80 to 90% of these people do just fine with a 651. It's very rare that I ever order a 652. So that's interesting to see those numbers. I'm going to move on.
Maybe you should let them know that the rest of anything that is not in the picture is relatively normal.
Yeah, even if, yeah, anyway, I don't know, even if it's, I just don't think as a whole, even if they weren't normal for the most part in legs that you can just envision what the stomach probably looks like, I'm still going to go with the 651 the majority of the time.
Yeah.
That's just, and no right or wrong answer, but that's what I would do. So here,
Steve, what about,
yeah.
Can we incorporate this question into your presentation? There's a question that says, what if like that previous patient was responding to conservative complete decongestant therapy, but would like a pneumatic pump or benefit from a pneumatic pump due to back pain or limited ability to complete the self-MLD effectively? Would that person, I guess, be available to get a pneumatic pump?
Yeah, they still should with proper documentation. If you just document the cutaneous manifestations or still having symptoms, et cetera, you can. It's very rare that you cannot get a pump in that scenario. I know what the language states that you're referencing, but it's so rare that you can't get a pump approved.
And really, CDT is you can't really, unless you're doing self MLD, is not something that could be long standing. So if the patient obviously, undergoes early therapy with MLD, after a month or so, they're going to have some type of home therapy. And,
yeah, because all those gains will be lost. That's a great point.
Yeah. So if they can't do it on their own, it's like, you can't put a stocking on, you're not going to be able to. So you got to figure out a different solution, whether it's Velcro wraps or a pump in this situation. For sure.
Yeah. Okay, so here is a case of acute lipodermatosclerosis along the distal medial calf. Here's a case of chronic lipodermatosclerosis and a even worse case of chronic lipodermatosclerosis with these singular disfigured atrophied legs. So these are all complicated cases of phlebolymphedema. Now, I would submit to you the majority of the time, you're still going to start off with a 651. But let's say with the case on the right, that inflamed plaque is exquisitely tender. The patient can't tolerate the pressure of a 651 overlying the area. Well, this is a reason to order a 652, which allows you to selectively manipulate the pressure within the chamber overlying this affected area. So you would lessen the pressure. Now, conversely, in these latter two cases, and Tony, I think you alluded to this, these cases would likely require higher pressure within these densely fibrotic legs and tissue in order to affect change. So you're going to go with the 652 over a period of time, potentially. 651 or 652. Again, phlebolymphedema has been complicated by venous limb ulcers. I still submit to you that in the majority of the cases, you're going to start with the 651. The patient may do fine. There's data to suggest most of these patients do fine with venous limb ulcers with the 651. However, if they can't tolerate the pressure of the chamber overlying that denuded integument, then a 652 that allows you to selectively manipulate and decrease that pressure is going to be a better long-term treatment option. 651 or 652? Well, you know what? I would actually say neither, at least initially, because we have a contraindication here to utilizing a pump. Contraindications include skin infection and or inflammation, and both of these legs obviously are quite inflamed and are obviously infected, so it would be a contraindication to use in either of these scenarios. So I just wanted to point that out. It's always useful to talk about contraindications. Now, in both of these situations, we have lymphedema extending to the inguinal ligament because both of these patients underwent a previous pelvic lymph node dissection. What would be the ideal selection, a 651 or a 652? We're polling the audience again. Oh, outstanding. Outstanding. Yeah, and I completely agree. I mean, the risk that you run, if you don't selectively or preemptively activate what residual inguinal lymphatic function they have with the sleeve of a 652, you run the risk of that just isolated sleeve with the 651 actually provoking or worsening inguinal pelvic lymphedema. So definitely a case for 652. And I would point out on that slide you showed, Steve, there are cases with insurance companies, if you initially document, I mean, you have to go through those documents, your 4 weeks of conservative therapy, elevation, exercise, or compression. But if you can show a unique characteristic, like these patients having pelvic lymphedema, a lot of times you can go directly to a 652. So the audience is on board. I like it. Must be a learned audience. So here we have an inflamed, tender red leg in the setting of lymphedema, 651 or a 652. Well, hopefully you recognize this as cellulitis, and cellulitis is also a contraindication for utilizing a pneumatic pump. You know, ideally, you're going to put them on antibiotics within 48 to 72 hours. When the pain and tenderness and redness start to dissipate, you'll be able to utilize a pump. Of course, initially, I'm going to say a 651. All right, tough choice here, 651 or a 652. Gosh, two highly illustrative cases of just unfortunate disfiguring scrotal lymphedema. And this really should be a slam dunk case of you go right to a 652. I mean, a 651 is not going to be an appropriate pump because remember, all you have is a leg sleeve that extends to the inguinal ligament. So it's not going to affect change. You need a pelvic sleeve right across that swollen scrotum. And then the other problem you run into is that 651 sleeve may actually worsen the scrotal edema without preparatory pelvic clearing through a pelvic sleeve provided by a 652 device. All right, 651 versus 652. Tony, what do you think about these legs here with the lymphedema that they have? Well, here I'm actually showing you symmetric fatty limb deposition that's disproportionate, as seen here on the slide on the right-hand side of your screen, without foot swelling. These patients have lipedema.
Yep.
So in this case, I think a lot of times, and now when you have lipedema, one of the hallmarks of lipedema is cutaneous hypersensitivity and even touch allodynia. These patients don't tolerate much pressure. You may be forced to initially prescribe a 651, but a 652 device, it allows you to selectively decrease the pressure and all the pain.
Every time, but not everybody.
What's that? So anyway, so a 652 device, especially the FlexiTouch, is a very good pump to utilize in the lipedema population with cutaneous hypersensitivity and touch allodynia. Were there some other comments?
No.
No.
Oh, okay. 651 or 652.
Another
Well,
contraindication.
Another contraindication. Absolutely.
Yes.
In fact, we have two contraindications here. Number one, severe PAD with critical ischemia and gangrene, and actually a skeletonized foot. Probably not the best to utilize a pump in this situation. And our second contraindication, let me give you a little close up here, would be a maggot infestation or any type of infection. Now, just as a fun tip here, are you familiar with what the medical term is for maggot infestation? It's actually myiasis. So that's a little take-home point. I hoping to interject that at a cocktail party sometime. All right. Moving on, 651 or 652. This is a case of a swollen, incredibly painful foot. It's been going on for a year after an ankle sprain. This is complex regional pain syndrome. And as you know, these patients have touch allodynia. So it's highly doubtful they're going to be able to tolerate a 651 pump, even at low pressure. And that's where a 652 device that allows selective manipulation, decreasing the chamber over the foot especially, is going to be beneficial. All right, 651 or 652. So what do we have here? Two highly illustrative examples of massive localized lymphedema or pseudotumors along the medial thigh. So in this case, this is an interesting case. As a whole, your 652 device is a better way to go because you can get extended sleeves with that, because these patients are clearly going to need an extended sleeve. No question about that. But apparently Tactile can still get a 651 device with extended sleeves. It can be done. It's not first line. It's going to be hard to get. And then the second issue would be, which I think Dr. Elias was referencing, is what if you have an abdomen that looks like that, an abdominal panniculus? That's where the 6.2 device is going to be better, because you can affect change on that abdomen and clear some of that lymphedema within the abdomen before you start the leg sequence. And our last examples, this is just to get oriented here. That's the abdomen, and that's a suprapubic panniculus. There we go. There we go. What are we looking at here? Abdominal panniculus with elephantiasis, also known as abdominal panniculus morbidus. And we'll poll the audience here on this final slide.
%.
I hope so.
Let's go with I hope so, Tony. Let's see here.
All right.
Maybe it's supposed to be there. Maybe that's just a joke. They're being obstinate, but
It's always one.
there's always one. So similar to the scrotal edema, you can't use a 651 because you've got a sleeve that just goes up to the inguinal ligament. How are you going to affect change on an abdominal panniculus with the leg sleeve from a 651? You have to have a 652 to compress the abdomen.
All right. Can I have an audience poll before we get to Mando quickly? Could we have a true or false, Janet, for these patients here? True. I see many of these patients. I see many of these patients. True or false? These patients on this slide. True. If I see many of these patients. True. If you do, say true. False, say false.
You realize these are from my practice. These are real life cases.
I know that, Stephen. That's why I'm asking this question.
Yeah.
Steve, how about labial lymphedema?
I don't see a lot of that. When I have, it's in the setting usually of previous pelvic lymph node dissection. It's rare, but I see it, and it's usually not anything on the scale of this. It's rather modest. I don't know about you.
Would that patient be a 652 candidate?
Oh yeah, absolutely. Yeah, definitely a 652 candidate.
All right, so here you go, Steve. You are uniquely seen. So 87% of the people do not see patients like this all that often. And I can say that I'm in that 87% category. And Tony, are you like that? Are you seeing a lot of these kind of people?
Well, what's your definition of many?
Yeah, that's what I was going to ask. How do you define many? Yeah, because I don't see many of them, but I certainly see.
The first two panels I'll see maybe a handful a year.
At most.
Yeah.
Manu?
Yeah, I would say probably maybe a dozen or so a year.
Yeah.
Hopefully they're getting, recognized by their gynecologists, urologists, family doctors. I mean, they're not usually presenting this severe, but we've seen, I'm sure all of us have seen some severe cases.
Yes, but not to this extent.
Yeah,
No,
you just marvel and go, how did the patient get this far along when they came into your office?
Right.
I definitely have not seen the patient to the right.
Yeah.
No.
Maybe one day, Tony.
Maybe. Okay. Steve, as Manu is pulling up her slides, can you get a 652 covered for lipedema without any skin changes?
You could, because what you would put is you would just put pain and tenderness as a unique characteristic. That's what you would use. It's a unique characteristic. Intolerable pain and cutaneous hypersensitivity. It can work. You could always, what you could do, and I'm not suggesting fabricating anything, but there probably at some level is some level of cutaneous fibrosis in a lot of your lipedema cases. There just is. So that would be legit.
I think there was one other question. It says, I have a patient with a ventral hernia, a VP shunt, bilateral lower extremity edema. Is there any contraindication?
No, I think that'd be a good case for a 652 FlexiTouch. Very good. Very good. Because you can select, I think that's actually a very good case for 652.
Okay, perfect.
That's actually in some of their data from their company. They'll specifically reference those exact situations.
Great. So I'm going to talk a little bit about how we manage lymphedema in our practice. We do have a certified lymphedema therapist in our practice. We've had one for about 7 years. We follow our lymphedema patients like many of the other panelists on this panel tonight, where we're managing their lymphedema, seeing them at least several times in the first 3 months, usually once at their initial and then usually 6 to 8 weeks later. And then usually every 3 to 6 months, depending on, their support system, their ability to don and doff their compression, as well as their pump usage. If we've decided to use, flavonoids in their management, and things like that. So we do follow our patients with lymphedema pretty quickly. There was pretty often. There was a comment on there about having the tactile rep doing the measurements and things like that. In our process, our clinicians, whether it's myself or our nurse practitioners, are evaluating the patients. And once we've made that diagnosis, usually at their initial consultation, we will see them back about 6 to 8 weeks, because in that time, we've hoped that they've gotten into lymphedema therapy. And so when they come back in for their second set of measurements, if you will, from our practice, those also get put into their note and sent to Tactile or another lymphedema pump company, whatever the patient chooses, or whatever we feel is most beneficial for the patient. So it's not a conflict of interest, if you will, as one of the questions had mentioned. So let me see how I can advance this. Oh, I just have to click it. Okay, I have no disclosures. So I'm going to show you a couple patient cases that we've had in our practice, and hopefully you guys might be able to, say, hey, that looks like something that I've seen in my office, and consider doing a pump for these patients. So this patient was referred to us by podiatry. We get a lot of referrals from podiatry. The patient came in, we did our initial consultation. They did not have any chronic venous insufficiency on ultrasound, meaning their reflex study was completely normal. Of course, they're wheelchair bound, so you kind of have to think about their pump function of their calf. So they probably don't have a lot of pump function since they're wheelchair bound. And there's a lot of dependent edema there. There was a lot of drainage, so we did swab the patient. They had serratia. We treated it with ciprofloxacin, and then began lymphedema therapy after the antibiotic was on board. And we immediately started the pump referral so that it can be started with Tactile, so that they can start working to see what the patient may or may not need for their documentation so that they can get a pump. So this particular patient was referred to us by primary care. Obviously, you wonder when they present like this, why did it take so long to present like this? This patient underwent, again, an ultrasound study in our practice, found really minimal reflex that was really just a finding, an incidentalloma. We did place this patient on an antibiotic, set him up with a local lymphedema therapist, because we do work with our local lymphedema therapists in our area, depending on where the patient lives. We want to make sure that they're not having to travel very far for their lymphedema therapy. Usually when they see a therapist, they're seeing them at least once or twice a week. And those therapists are performing manual lymph drainage and then talking to the patient about compression therapy, whether it's an inelastic wrap of some sort, whether it's a flat knit versus a circular knit. So there's a lot of education that the lymphedema therapist is doing with the patient. Skincare is one. Who do they live with? Can somebody wrap them with a short stretch? There's a lot of things that go on to get this patient prepared to basically be discharged from therapy so that they can use their pump at home. And so oftentimes these patients, they really love their pump because we tell them, if you have your pump, one of the nice things is, especially in June, July, when it's super hot and they really don't want to wear their compression garment, they may use their pump even twice in that day because they really want to be lazy with their compression garment. And so it does give them sort of some freedom, if you will, and some saving grace with their lymphedema so that they don't necessarily have to wear their compression stockings 24/7. So it does give them a little bit of an out. This patient ended up having an entree trial and then converted to Flexi Touch because of abdominal swelling, which we saw on their subsequent follow-up about 6 weeks after starting therapy.
Yeah. So Manu, just a couple of things for the people that are listening from a practical viewpoint. And
Sure.
you just inferred one of the questions I was going to ask you, which was, let's let them know. So you start pump therapy. First of all, what expectations do you say to the patient? In other words, the patient is going to say, "Oh, I'm going to use it, for 4 days, and my leg's going to look like normal again." Or, what do you tell them? It takes X number of weeks to see an improvement, and then we want to see you back after those X number of weeks to see how you're doing, if we need to modify things or anything. So, I mean, we made the point before, it's usually like 4 to 6 weeks you tell them it's going to take to see something. And that's in general when you want to, take a look at them again once you've instituted pump therapy. Would you kind of agree with that, to give people an idea as to when they would see those patients after they started pump therapy at home?
Yep, I would at least see them at least 4 to 6 weeks after they've started, whether they're starting MLD first, because some patients don't want anything to do with a pump. We have that discussion with them on their very first appointment. Some patients are like, I'm not sure, I would rather just do therapy first, or my finances are not that great at this point. Can I just do one thing? And so, we have that discussion with the patient. We bring them back in 4 to 6 weeks. And then if they've started pump therapy, we bring them back again in 4 to 6 weeks. And so you are seeing them a little bit more often in the very initial phases, just to, again, it's an opportunity for you to talk to them about their skincare, about their compression garment, their routine, and things like that. And then also for your documentation for the pump trial, if they need to move to a 652 after they've been on the 651. So there's a little bit of a process protocol that you need to establish in your office on how often you want to see these patients. But typically, like you said, Steve, it's 4 to 6 weeks after they've done, MLD, and 4 to 6 weeks after they've started their pump.
And how about patients, anybody on the panel, what, in general, since we already said fleeable lymphedema is one of the main causes of swelling in the United States, are we almost always looking at the venous function in these patients as well? I mean, we are more often than not. Steve, you want to tell us when maybe you don't need to, or in general you should?
Personally, when I've got somebody like the patient that Dr. Agrawal just showed, that's in a wheelchair, that has no calf muscle pump function and is just essentially immobilized, and especially with a BMI exceeding 45 to 50, I don't really pay much attention to any reflex, et cetera. I just that's what needs to be treated: their calf muscle pump and weight loss initially, anyway.
But in general, patients such as the picture here and stuff, and the other two, you want to take a look at the venous function and at least.
Oh yeah, I'm going to do an ultrasound. I just as far as, but what are you going to do with reflux if you?
No.
Yeah,
you may not treat it, and some of the insurers are almost requiring us to have a venous study to really more document that there's no DVT and stuff.
Sure.
Right. So we need to make that point to everybody that even if you don't think you need it from a functional viewpoint, many insurers want to make sure have documentation there's no DVT. When it's obvious to you there's no DVT, but that's maybe a requirement.
Yeah, definitely.
Yeah, it's a great point, because I think, we talked about this AVLS or UIP, and, some of these patients, they're so edematous, it's difficult to really assess their venous function, but you really want to make sure that you're not missing a DVT, or, some of these patients have had a DVT in the past, whether it's even superficial venous thrombophlebitis, and they didn't know because it just felt like a pulled muscle. Magically, you've seen, some scarring of the vessels and things like that. So I think it is, you make a good point to make sure that you are evaluating these patients first from a venous standpoint, and also, continuing them with their therapies.
Yeah, my comment is I find it extraordinary when you have these patients with BMIs of 60s and somebody orders a complex venous mapping on them. I just kind of shake my head.
Yeah.
But I would say,
Yeah.
80-90% of the patients that walk in will get an evaluation of their venous system.
Oh yeah, always rule out DVT, definitely. Yeah.
Yeah. So this particular patient, let me see if I can go back. This particular patient, I'll go really quick with these because we're almost up with time. He was a type 2 diabetic. He came in with this lateral wound on his leg that had been there for over 7 months. He had a basic pump at home. He wasn't, using it as often as he should have. We started seeing him and using actually short stretch bandaging with him, and then also setting up with lymphedema therapy. He lost 130 pounds, wearing his inelastic wraps daily for maintenance of his lymphedema, using his pump daily. It's a pretty, usual success story for patients with these wounds and lymphedema. Similarly, this patient here, we had to do some injections for this patient to treat his venous insufficiency, but he has Klippel-Trenaunay syndrome, and so he had history of multiple DVTs, post-thrombotic, and so we were able to also get him down to this one tiny little wound here that you see, using the Flexi Touch at home, and then obviously coming to us for his wound care. So this we've already answered a lot of these with Steve asking some of these questions. I think the biggest thing we like to always tout about is, having clinic-based versus hospital-based lymphedema. We find a lot of our patients are really happy that they're not having to go in and find an elevator, and, they're already having mobility issues. We carry short stretch bandages in our practice, as well as compression garments, so they can get them right then and there without going through DME. And then oftentimes some of these programs, they may not have all of their therapists certified in doing lymphedema therapy, or they're using kind of an assistant, if you will. So we kind of tout ourselves a little bit with that. And then, like I said, we are evaluating these patients regularly to make sure we're not missing anything from a venous and a lymphatic standpoint. And then why tactile? Of course, our rep is really important, not only for us, but mostly for our patients is the biggest benefit that we see. The tactile rep is in constant contact with our patient. If there's ever an issue for anything, like where is my pump or where am I in the process, they will definitely give the patient a call back, which is nice because then that's not my time and staff to call and figure that out. And then, they're doing the prior authorizations for the pump in-house, so that's something that we don't have to do. And again, the communication and weekly updates are really what keeps us really successful in keeping our patients unburdened by their lymphedema. Okay.
Nice.
Excellent. So any residual questions here? No, right?
No.
I think I answered the last one.
Yeah. All right. Any final comments or? No, we're just on time, 9 o'clock. I mean, it was perfect.
Yeah. I just
Well, I hope this, kind of cleared up some of you out there, because, even for most physicians, they really don't even know what the difference is of a 651 and a simple and advanced. So I thought this would be very helpful to just get the basics out there and how, determine what patient to order what and what's the requirements to get access to care for patients. So just to wrap up things, thank you, everybody. Dr. Agarwal, Steve Elias, Dr. Steve Dean, really great talks. I think very informative. And just to leave you with some upcoming medical education programs, as you can see here. I'd like to thank Tactile for organizing this. And for those who came on late or missed part of this, we will be sending this out as a recorded link and will be available also on the Tactile Education website. Thank you very much and have a good night.
All right, good night.
Thank you. Good night.